All right. Thank you so much, guys, for joining us today. We're going to get started. If you can hear me, please. Good. All right. Thank you so much, guys, for joining us today. We're going to get started. If you can hear me, please. All right, it's good. It's good to be here. This is Sunday afternoon here in Cedar Park, Texas, and I do have my very good friend and brother and co-collaborator with me this afternoon. And I know it's still morning. What time it is? Is it in Seattle, Washington?
Hello. It is 10 a.m., but it's perfect time.
All right. All right. We have been on this journey for a little bit. Today, I just want to share a little of our history, and I do hope you can take some less, take home some of the thoughts that we're going to share today. You are going to be presenting on implant placement in a periodontally compromised site, right?
Yes, that's correct. Thank you very much.
Okay. All right. I'm going to get started here. Um, I bring you greetings from the mission field. I'm a missionary dentist, and I get to participate in a lot of outreaches in different parts of the world. Just back from Kenya and Guatemala a couple months back. Always a joy. And this is an invitation, actually. So if you are interested in serving, we do have trips planned to the Dominican Republic, to Mexico, to other different parts of Kenya, in Nigeria, Ghana. If you want to be a part, please do take our information so that we can go out there. Like I said, this is what. Hopefully, one of these days we're going to go to Brazil again, Ethiopia, Haiti. These are very close places, very very close to my heart. And dentistry, actually affords us to be able to give back in ways that many people cannot, because it's not that difficult for a dentist to share what they have. We do have an education mission coming up in Cameroon, in Ghana, and in Nigeria, January, the beginning of next year. We're going to be there. So if you want to get in touch, take a screenshot of this. This QR code leads you to our Instagram page. You can send me a message if you want to be a part of that trip. Do let me know. It's going to be implant training in Cameroon, implant training in Ghana, implant training in Nigeria. So some of all these things we've been talking about, after watching these videos, I want to come to you and do a hands-on, so that we can just make it real, and hopefully we can increase your skill and your confidence in treatment planning your patients. Anyway, I do believe that you cannot live a perfect day without doing something for someone who can never repay you. Very good. Some thoughts there. My journey into this collaboration started when I attended University of Michigan. Great school, great people. And that's where I met Dr. Ricardo. We were on the same floor. So, on the same floor. And here we are many years later talking about, the things that we have learned from each other. Anyway, I did start this journey just in that same floor. I was working on a computer and showing, Dr. Razug, who was in charge of the program at that time, and that I wanted to be able to send information to different parts of Africa. And we are still on that journey to be able to increase implant utilization by dental students and just dentists in different countries. So I have Africa all set up. I have a map on my room, every country We are trying to get information. So this webinar is going to be shared to all dental schools in Nigeria. Whatever recording we're making today is going to be watched by every dental student in 11 dental schools in Nigeria as something, to boost whatever they have going on. So when we finish these online sessions, I want to come to your country. This was when I was in Kenya a couple months back, and I'm coming to Cameroon. I'm coming to Ethiopia. So let's, if you have any contacts, people who are willing to work with us, let's do it. So we started doing this collaboration with Dr. Gainfilippo back in 2020 during COVID. We sat down and we said, what can we do to advance dentistry from from our computers? What can we? I began to think, and we began to put lectures together on how to advance dental implant uptake by dental schools in different parts of the world. And today we have moved from these webinars. We are now part of a group called the International Implant Institute that offers hands-on training in the United States. So if you are watching and you are interested, we do have class coming up in November. So we have taken this that you're watching right now, and we've put together with Dr. Julia Jackson, Dr. Ibrahim Haroon, and with both my friend here, Dr. Ricardo Gianfilippo, and we are organizing Implant Prosthodontics Mini Residency. It's something you want to take advantage, share this, take a screenshot and share this. If you click on that, that QR code leads you to the website so you can see. There's a fee to it. But it's the best course I've attended in recent times. I've attended so many courses, I've paid so much money, but this is value added. You can be sure of that. Anyway, today we're going to talk about interdisciplinary strategies in periodontics and prosthodontics. So how do you have a predictable outcome? Like I said, I got to see this patient because Dr. Gianfilippo had, consulted with this patient, and he, were thinking of what to do and coming up with a plan. And he reached across the aisle from where he was and said, what, by the time we are done, this guy is going to need some teeth. So and the Prosth department was just close by, and we began to communicate. So I saw pictures, I saw X-ray, I saw CBCT, and we began to communicate, in terms of come up with a plan. How do we meet? So that's the essence of of this presentation today, to talk about what it takes to achieve some kind of successes. There's some things you can do by yourself, but there are some things you cannot do without another person joining you to achieve it. So the ability to collect and correlate data across specialties and to sequence it and to coordinate multi-phase treatments, it's competence that you need to acquire. It's something, it's not something that just comes to you. You have to work at it. Being able to, especially the sequence and the treatment phases, is something you need to have a plan for, in terms of how are you going to communicate your ideas or whatever you want to do with the other team. So it's something that is why I'm here today, to say it is something you should plan to learn. I've been looking at all literature, and prosthodontics and periodontics are collaborative disciplines. You cannot do it by yourself. We collaborate for a massive, impressive outcome. There's this book. This book is out of Seattle, right? The Seattle Study Club. It has become a huge. These guys in Seattle have they've made a name for themselves by doing things via interdisciplinary planning and execution. So Michael Cohen did say the treatment planning is optimally managed when it's in a partnership, because you know your portion, the other person knows their portion, but when you come together, then you can receive, you can get, maximum outcomes, better outcomes when it is planned together. So collaboration, is a foundation, that brings individuals together. So if you look at this case, patient came in on the left-hand side of the photograph here. He came in and I was, okay, I think he needs some, we don't have, how are we going, we need some room. And so the periodontist is right there close to me. I'm like, can you get me 3 millimeters of crown lengthening, functional, crown lengthening? They're like, wow, okay, yeah. You don't want to go ahead and start planning a treatment when you don't have room. So we looked at it together and the periodontist achieved that for me. So when I'm going back in there to prep my crown, wow, I have so much room. So collaboration is key because everybody brings their own strength to the game. He did say, Michael Cohen also did say that, it is more, there's more credibility in the eyes of your patients when the team is consulting together on a case. So it gives the patient, a lot of confidence in whatever you are bringing out when they know that you have talked to their oral surgeon or you have talked to their periodontist and you guys have, are not, it's not like, oh, A is doing something and B does not know. So the patients are more likely to accept your plan when they know that you have collaborated on their case with another specialty. When we plan in isolation, we are limited by our own weaknesses. Because as a provider, I know you're an expert of some sort, but once you do stuff in isolation, especially you're trying to do ortho, you're trying to do, this patient is being seen by an orthodontist, our patient is being seen by an orthodontist. Our patient was being seen by an oral surgeon. Our patient was being seen by the periodontist for guided tissue regeneration. And the patient at the end of the day needs some teeth. So you have 4 specialties working together to give you. So when you see the outcome, you better believe that, we have shared knowledge and we have shared our strengths. So, even if I'm weak in one area, my friend who is working with me brings his own strength. So what is the goal? So as a prosthodontist, they usually say that the prosthodontist is the quarterback of the treatment plan in terms of where are we going with this. I'm trying to achieve to restore interarch and intra-arch occlusal stability. That's where I'm going. How do we share the load? This patient comes in and he needs an implant. And how do we share the load? That's what I'm thinking about in my restorative planning. How do I create a definitive occlusal and proximal contact? So I'm thinking about that without leading to over eruption of the adjacent teeth or shifting. So I'm thinking about, I have my goals and I'm thinking, I'm talking to all my team members. So this is the plan and how do we achieve it? First of all, we have to make a diagnosis together. So every specialist must agree that it's the same problem. So we making a diagnosis is the prerequisite. So when you talk with your teams, when you talk with people you are collaborating with, you must have a prerequisite to make a successful therapy is by having a good diagnosis. So when you look at this patient, I'm gonna just jump on here with Dr. Gainfilippo. We've not talked about this patient before, but I just want to, Dr. Filippo, what do you see when you look at this patient?
For sure, I see some partial dentulism, some caries, some vertical ridge deficiency. I want to double check with you, how is the occlusion of this patient, if any changes has occurred. I would say this patient necessitates of a comprehensive diagnosis to see the list of problems, and then from the diagnosis we move to the treatment plan. What is the best way to rehabilitate these patients for ultimately to improve the patient's quality of life?
Perfect. I mean, so we all see you are saying it, and so we come together and we say, okay, yeah, you know what, this is a problem I have. How do we? These are all the problems. There's super eruption there. The occlusion is right there. It's only touching occluding on one set of teeth is what is touching. So it's like, wow, how do we achieve this? So we'll sit down, we discuss, we take records. diagnostic record, we take photographs, we take a CBCT, we mount the case. With that, so we have things to items to look at together so that we can come up with a plan. And each person comes up. Is the midline coincident? So we start thinking, what are we going to do? How much bone? So when we gather all that information, that's when we start really, really collaborating on the case in terms of you must look at the same things together. So with some patients, the restorative dentist cannot accomplish the correction alone. You just like this patient comes in and I determined that there's no way he didn't have any much bone in the maxilla, and there's no way. So we needed a fixed option. There's no denture was going to fit. I'm like, okay, oral surgeon, periodontist, can you get me a quad, can you get me a quad implant in there? Okay, the guy says you can, this is what it's going to cost, so we can talk about costs, right? So you must talk to your partner and start talking about costs, talking about what it's going to take, the time, come up with a timeline so that patient understands. So there's some things you're going to achieve. Patient comes in and when he got the quads, it was time. Then, after one person finishes, then it is sequenced. It is multi-phased, and we can follow a plan. So all this comes together. So some people say, they don't like working with other people because of maybe costs, or maybe some patients don't even want to, so you must have all this taken care of, the time and the scheduling, because the periodontist needs his time, and you have to have another time to come back to your restorative dentist. Or maybe we live in two different places. Right now, my friend is in Seattle. I'm in Texas. Can we collaborate on a case? Some patients can travel. Team conflicts, the imbalance between the workload and the fees. I'm spending too much time. So these are some of the reasons people say, well, you know what, I don't want to get involved in, interdisciplinary dentistry. But if you look at it, it's more, you solve more problems, and you can change your perspective when you're talking to other people, because everybody comes with their own perspective and they see things that you do not see. And you can modify and just learn something, develop links. You can just, instead of standing alone, interdisciplinary dentistry gives you an opportunity to expand your own discipline, get some things you're going to learn for someone else. So there's so much more. I believe there are more. Dr. Gainfilippo, what do you think about collaborating?
I totally agree and share what you've said so far. For sure, it's very important to collaborate and exchange ideas. Everybody has different perspective. And ultimately, we collaborate to do what's best for the patient. So it's good that different professionals may have different experience, different background, may bring different points of view, and then the group chooses what's the best for the patient. What you also said is it's true that often the challenges of the multidisciplinary treatment plan is that it increases the cost for the patient. It also increases the number of appointments, because if there are different providers in different locations, then the patient needs to travel in those different locations and do different consultations. And while in a school we were across the corridors, where we could call each other in Michigan, in private practice now, the patient needs to do different consultation in different buildings, and perhaps increase even the cost of the consultations may multiply. But when the patient has a more simple scenario, then it makes sense that fewer providers in the same location can address the concern of the patient in the best way. As the clinical scenario becomes more challenging, then it's very important that the first provider makes a judgment call and can decide if it's something that they can do on their own with the collaborator they have next door only, or if it's important to refer the patient to different specialists, as the case you showed with the midline modified, only one tooth in occlusion, over eruption, and possible ridge deficiency. That is a very difficult case, and
Yes.
for case of that extent, then without any doubts, multidisciplinary collaboration is needed to give the best for the patient.
Awesome. Awesome. Thank you much. There's a paper here I did see talk about the 10 principles of a good interdisciplinary team. That the healthcare teams usually face a set of challenges. Just the contentious nature of sharing professional roles and expertise. So there's a level of humility that learning gives you. Some people, there's some teams that can't work together. I'm telling you, I've seen it. Because everybody feels, well, I'm the king here. This is where I see it, and that's the way it should be. But you just have to be able to share in a humble manner your role and your expertise, and when planning and in making decisions, there's going to be that shared. It's shared for the interests of the patient, like you mentioned. It's for the interests of the patient, not because of how much you know or how much you have, but we are trying to achieve a goal, and everybody's trying to get paid too. So for the interest of the patient, we come together as a team to work effectively. And some of the things that we need to do, here is create a climate where we can contribute, value to the case, where you can bring your personal qualities, where there's a lot of trust between the two providers, and communication is key. There's got to be intra communication, there's got to be formal communication, there's got to be shared case notes. Without a good communication knowledge and practice and being able to listen, if you can't listen, like with anything, if somebody is telling you something and you're not listening, then it's not going to happen. So it's going to be closed loop. Like CPR, somebody says, get me the AED. You got to be able to tell the person back, okay, I understood what you said, and that comes to play in treatment planning and leadership, in terms of what role are you playing? Are you bringing your personal characteristics? Are you able to learn? Is the patient the focus of this holistic care? Are you, so this, if, I believe this slide kind of helps you. So if you need to work with a team, you need to be able to put all these things together to get the outcome that is desired. I saw this paper. It was written by, I think, a friend of one of your professors, Dr. Gainfilippo. His name is always on many papers. I think that's Homely Wang, right? Is that Homely Wang? I've seen Wang H. Hell. It looks like. So he did write this paper in 2015, where they said periodontics and prosthodontics is a two-way street. That we share an intimate and an inseparable relationship in multiple aspects, in treatment planning, in planning, in executing the procedure that we have planned, in the outcome, and in the maintenance. This is not about blaming one person. Oh, you guys did that. I've seen a lot of things that shouldn't, and I think it's best when we work together. This really gives a good indication. I looked at another paper by Dr. Avinash Bidra, that when we do not plan, when there's inadequate treatment planning, things go wrong. Things go wrong when we don't talk to each other. Things go wrong, especially just look at implant positioning. Imagine I don't give you an indication of where the crown will be. We didn't have a discussion, and we go and place the implant, and what's going to happen afterwards? You cannot restore it. So it is critical that we sit down together. We can talk about. So this is a table here by in that paper that talked about just details of parallelism, dimension of implants, the number of implants, the choice of the implant system. Dr. Gianfilippo, do you think this it is is this too much to collaborate on in terms of these specifics?
Actually, it's very important. This collaboration, the need for communication, knowing all this information, I don't think it's too much. This is actually extremely important. For example, I need to know if I need to do bone reduction because it changes the much restorative vertical space you have. And I need to know how many implants I need to place. I don't want to place too few, and then it gives a restorative problems for you.
Mm-hmm.
The
Mm-hmm.
dimensions of the implants, for example, in width can changes the dimension of the platform. That is something that influences the restoration. So I believe these are all extremely important factors that needs to be discussed during the planning phase before we actually move to the surgery. I mean, once the surgeon places the implant and the implant is also integrated, at that point the implant stays there. It's very difficult to
Yes.
make modifications at the point. So everything that needs to be discussed needs to be done during the planning phase. And after everything is clear, only at that point we can move forward with surgery.
Cool, good, good. Collaboration requires competence, confidence, and commitment on your part. So everybody brings to their part their competence, their confidence, and their commit. So there's got to be commitment to the case. If there's no commitment, it's going to be like, this tripod is not going to stand because if you're not committed to it, because the patient comes in, if for some reason you just don't show that commitment, then at the end of the day, things are not going to work. So some of the key factors in collaboration is seeing this as a joint venture. It's something we are doing together. The cooperative endeavor, the willing participation, and the shared planning and decision making. So this it looks as if we're emphasizing things differently, but these things come if you don't have a willing participation. Don't just do it. If the other party is just dragging and not really involved, do not invest into that case, then it is not worth doing. I'm going to share here before we start talking about a shared case that we did together, that a team approach, a contribution of expertise, shared responsibility, and not a place where we are kind of, fighting over who is in charge or not. So we share the power based on knowledge and expertise. It's a lot of humility that comes with this stuff, for the interest of the patient. So we did, we're going to talk about a case that we did together. So patient comes in, patient had been under the care of an orthodontist. You can see brackets in place, braces, trying to create room and to keep space. And also, I'll give a little detail that I'll get Dr. Filippo to come into it. A 27-year-old guy came in, not a non-smoker, non-drinker. So in planning your cases, you still need to do some risk assessment. So in terms of medication, medical history, there are some things that we're planning to place implants for this patient. What would have been a red flag if this guy comes in with, what would have been a red flag in terms of medical history?
For me?
Yes.
Actually, I remember this patient. This patient was very young, 27-year-old, and at the medical level was actually very favorable. Often patients with severe bone deficiency, often they are old. Problems of older age is, for example, intake of anti-resorptive medication. Many of the patients may be smoker, diabetic with impaired healing. So for this specific case, the case you're about to show, the deficiency comes from orthodontic problem that then became an oral surgical problem. So the young age together with an acute type of deficiency, for sure it was a favorable scenario for bone augmentation. So in this
Yes.
case, from medical and dental history, uh, there are actually no contraindication to dental surgery. This case was actually medically very favorable. Genetics of a young patient, no no diseases, no factors that work against the healing.
Yes.
So for sure, at the medical level, this is a favorable case.
So these are the things that we collaborated about. So if we had seen something and say, okay, then we have to sit down and discuss. Okay, this is what he has. What can we do if he had other things going on? If he was taking a particular medication, would we say, okay, if he had heartburn, he was taking, a proton pump inhibitor, would you say, okay, yes, how do we get him off of that so that it becomes more favorable? But thankfully, his case was that. So he had an horizontally impacted a canine, and he had his retained C. Yes. And this was how the patient came, and we began to think of what we were going to do. So this was how the case started. And how did we bring in the oral surgeon in this case? Because we sat down, we began to think of what we were going to do, and we needed that canine out of there.
This patient, so as you correctly said, this patient had this impacted canine, and they retain the deciduous canine. And I met this patient after the canine was already extracted in oral surgery. This canine was extracted even before the patient started with orthodontics. And first the deciduous canine and the permanent canine were extracted. Then the patient started orthodontics. And towards the end of the orthodontic therapy, now is the moment to think about placing implants. As different specialists collaborate, they can draw together a treatment plan. And usually extractions are done, the patient undergoes orthodontics, and towards the end of the orthodontic therapy, now it's time to plan the implant. And as you will show in the next slides, the problem that I found when I saw the patient the first time is that there wasn't enough bone volume for placement of the implant. So the surprise that I received is that when I saw the patient the first time, this is actually what I saw. So when I saw the patient the first time, the damage, the bone resorption had already occurred. So at this point, a series of discussions were made depending on different treatment plans for this patient, different surgical alternatives with or without bone augmentation procedures. But to place implants in this case, then for sure some site development techniques and bone augmentation, they had to be done. As this slide shows, then there was only less than 2 millimeters in the coronal area and buccal and lingual concavity with some apical fenestration, with addition between the buccal soft tissue and palatal soft tissue. So then, as you will show, the case will continue with some bone augmentation techniques and ultimately a dental implant.
Yes, so I was just going to piggyback on what so we saw this patient after he had gone to oral surgery. What would have been different if we were all part of the planning before the extraction? Do you think that at the time of extraction that some augmentation should have been done? What are your thoughts about that? If you had come into this case much earlier?
That's a very good question. If I see this, for sure, some type of bone grafting at time of tooth removal would have led to less bone resorption. The challenges of doing extractions and significant bone augmentation at the same time is that when you take out the tooth, then there is some soft tissue missing. So for example, and achieving primary closure might have been more challenging. As an alternative, we could have decided to just not to leave primary closure and do a more socket preservation type of procedure with a more advanced type of bone grafting. An alternative technique that I want to propose is actually doing both extractions without grafting, but then instead of waiting until the end of the orthodontic therapy for the bone grafting, doing the bone grafting 3 to 4 months later.
Okay.
this allows only for the soft tissue closure, and it doesn't give enough time for a significant bone shrinkage. So in this specific case, the only alternative that would have been benefit, because if I do the extraction and then we wait
Yes.
1 year for the orthodontics, then a ridge that was very wide, then it collapses to becomes 2 millimeters. But if we do the extraction, we wait, for example, 2 to 3 months, just enough for a good soft tissue closure, but not enough for a bone collapse. Then we can do a bone augmentation procedure in a more favorable environment. And I tell you that in this specific case, doing the bone augmentation early on during the orthodontic therapy could have helped facilitating the orthodontic therapy itself. There are actually several techniques that advocates for bone grafting during the orthodontic therapy around natural dentition to improve the plasticity of the teeth. And teeth can migrate within the bone boundaries faster and easier. So doing the bone augmentation early on during the orthodontic therapy for sure would have allowed first the reduction on the treatment plan, because now at the end
Yes.
of the orthodontic therapy, the patient is already ready for the implant.
Yes. To receive a tooth, you cannot.
Yeah.
Yeah.
Now the space was ready, and the CBCT. Now there isn't enough bone. Now we need to
Yes.
start another
Go
like
back.
9 months treatment plan to place the implant. So for sure, starting the bone grafting early on in the orthodontic therapy would have had some advantages, including reduction of the overall treatment plan. Perhaps doing a bone grafting when the defect wasn't that severe, and perhaps facilitating the movement of the neighboring tooth, because the bone grafting in this location, upper right canine, would have improved the plasticity of the local bone, facilitating the movements of the two teeth mesial and two teeth distal on each side.
Yes, yes. Anyway, I'll go on here. So, so when it comes to when I saw this patient, I think, the patient was in between. I think the GBR had started when I saw this patient, and for me, I was just concerned about prosthetic space. Are we going to have enough space? How is this implant? What's the emergence profile? Because it felt like it was very thin. There was nothing buccally, and where would you place the implant? And we started talking about prosthetic space, implant abutment, the framework. So you got to think about the end. Screw access channel. Are you going to use, your cement retain or screw retain? How much the teeth occlusion? Those are the things I begin to think about. And there are papers here that talk about restorative spaces required. So you must have this discussion in terms of, are you going to have enough space? So there's no point placing an implant if space is an issue that we need to sit down and talk about in terms of not just placing the implant. Do you have enough space to put teeth? And these are some of the numbers that we do have in that paper. This is a very good resource as you plan, because if you do not calculate space before you start placing implants, you're going to get into trouble. Because if you place the implant and there's no space, then the prosthesis is going to be too thin. It's going to break all the time. So you need to factor this in your discussion. And one thing that helps with this is a wax up. You need to put a tooth there. You need to do a wax up that looks at the location, occlusal relationship of the opposing dentition, the aesthetic, placement of the teeth in the anterior region. This is an aesthetic case, because a canine, and when he smiles, he sees it. So you got to put all this. So doing a wax up, and this today you can do this digitally. You can do it online, so you can put a tooth there. There's so many libraries of tooth. You put it there, angle, you can see everything. So all that planning is key. You need space. You need space for soft tissue. You need space for the abutment, and you need space for the material. So this affects even the type of implant you're using. Dr. Gainfilippo, if we had used an implant that was not that had the gingival collar, how would it affect this case?
That's a very good question. And that the epicoronal placement of the implant depends from the type of the implant we place. Often we refer to bone level implants, implants that are rough or at a macroscopic level called moderately rough or rough until the platform. And usually the implants rough until the platform are placed at the level of the bone or a little bit subcrestal.
Mhm.
Other types of implants have some smooth turned machine at the macroscopic level. They are called minimally rough surfaces in the more coronal area. And the height of this machine collar changes a lot depending from the brands. But most of the implant brands have some lines of implants with this smooth collar. Some of them are called tissue level implants or hybrid implants. Usually implants with a smooth collar tends to be placed slightly more coronal. Now, the roughness always has to be placed within the bone. The roughness always has to be placed within the bone. But if the patient, if the implant has a smooth collar, then at that point we can decide in that specific scenario if placing the smooth collar in contact with the soft tissue, or if placing the smooth collar to compensate, for example, some different bone anatomies. Let me give you
Mhm.
an example. Often we open the ridge and the bone is not ideal. The bone is not perfectly flat. The
Mhm.
bone often has some irregularities. Often the bone on the lingual side is slightly more coronal, and the bone on the facial
Yes.
side is slightly more apical. Then, in this case, using a tissue level implant or an implant with moderately rough surface until a certain point and 1 or 2 millimeter of smooth collar allows me to place the rough part of the implant fully in bone. And I can
Mhm.
use the smooth collar to compensate for this slope in the bone. So, for example, in this specific scenario that I pictured, the restorative platform still is in a favorable position, not too apical, not too deep.
Yes.
And then at a biological level, I'm using a smooth collar to compensate for this different bone anatomy. So overall, in aesthetic areas, we like using bone level implant, rough until the platform, placed deep into the bone. In a more posterior area, we would like to use some hybrid implant or tissue level implants with 1 to 2 millimeters of soft tissue turned or minimally rough surface. And this minimally rough surface can be used to compensate for different bone anatomies or to improve the apical coronal position, to give versatility to the apical coronal position of the implant. And this is
Yes.
how I would arrange.
Good, good. And today we do have some profile implants that describes the way the palatal is more coronal and the buccal is so the implants have like a profile where it is kind of slanted, and so to fit in. I know Dentsply has a new product that I saw recently, which just fits exactly into that kind of bone that is irregular. A good product out there. So this was the process of GBR, where you did go and make an. What you want to speak to this design? Why did you use this incision design?
Okay, yeah, thank you very much for asking. So in this case, we can see that the crestal incision is slightly towards the buccal side. And this allows, we know that we cannot really elevate the lingual palatal flap. So I make every time I do guided bone regeneration type of procedure or GBR, I like to make the incision slightly towards the buccal side. And in this case, I've opened 2 more teeth on each side. This allows me to have a wide, mesiodistally wide flap. It increases the blood supply to the flap itself.
Okay, good.
So this is the reason. And here we can already see how there is a knife edge ridge, very narrow, and we can see the buccal and lingual concavities. And in the upper right image, we can see in the apical part of the bone this small round communication between buccal and lingual side. So after we open, the first thing we do is we degranulate from possible tissue bristles, and then we make periosteal releasing incisions that can help us to mobilize the flap. And then we can choose different bone and membrane regenerative materials. In this case, I use a cross-linked collagen membrane. And the reason why I went to a collagen membrane is because for a horizontal augmentation, the collagen membrane is very well performing while reducing the risk of complications. For sure, this was a challenging case, and I had to grow a lot of bone. And the more challenging is the case, the more we want to use occlusive type of materials. And the most of occlusive type of materials is usually a non-resorbable membrane with some titanium reinforced structure. But for this specific case, because I wanted to decrease the risk of complication, and because the augmentation was mainly horizontally, not really on the vertical side, then I opted for a collagen membrane, the self-absorbable membrane, because still allows for good horizontal augmentation while decreasing the risk of complication that are usually found and higher for non-resorbable membranes or more advanced type of structures, such as titanium mesh, block graft, or advanced techniques. And in this case, I used a mix of bone allograft and autogenous bone scraped from the adhesion site. Another
Yes. Okay.
advantage, yeah.
Go ahead.
Please, okay. Just I want to say that another advantage of opening a wider flap is give me access for small scraper to scrape bone of the adjacent areas. So I didn't have to open, for example, the external oblique ridge from the mandible. Other surgeons prefer smaller flaps, but then they have to open different sites for collecting autogenous bone. We can also see a bone peak, a bone pin, a bone
Yes,
taxon.
I saw that there. Yeah, on the bottom right. Yeah. So that was just to hold the membrane, be sure that the membrane was.
If I remember correctly, this case actually pretty old, a few years back, but I used three, one on the palatal side, two on the buccal side, and I put one on the palatal first, and then I put the bone grafting, then I reflected the membrane facial, and this increases the stability of the membrane, and actually
Yes.
research shows that if you need bigger augmentations, then using fixation methods increases the amount of stability and also the volume of bone you gain. So I believe that a lecture needs to be dedicated only on bone augmentation techniques, but the long story short, the bigger is the volume of bone you need to grow, the more you need to add autogenous bone to
Fixation.
your materials, and
Okay.
the more you want to fixate the membrane to stabilize the
Stabilize.
healing.
Yes. Okay, cool. Anyway, so we did sutures there, and this was 2-week follow-up, 4 weeks post-op, and you already see some kind of increase in terms of the volume. So we did wait for a couple months before going back. 3 months follow-up.
That's
So after
right. That's why you continue.
Yeah, so after 3 months, patient comes back and with we did a radiograph at that point to see how much. Yes, this was a good day, right? Seeing this.
The reason why there are some images at 2 weeks and 4 weeks is to see that this patient, they see that everything went very well since the early phases of healing. Um, it's important that the flap stay closed during the early
Mhm.
phases of healing. If there is a flap dehiscence, then there is early contamination of the membrane. And
I see.
if there is a non-resorbable membrane, everything can get infected, and it's really a nightmare. The whole surgery fails. If there is the dehiscence of a collagen resorbable material, then there is early resorption of the bone grafting, and there is reduced bone gain. In this case, because of the favorable patient's biology and everything went very well during the surgery, then the early healing was favorable with a very uneventful healing. So 2 weeks and 4 weeks, everything was nice and closed, non-inflamed. And at 5 months, we can see a very favorable bone gain with an increase from 2 to 5 millimeters in the coronal area and an increase from 0 to 8 millimeters in the apical area. And we can see on the horizontal point in the lower right image how the ridge significantly increased horizontally from what it was
Mhm.
before to after.
Yes, the
Ideally,
concavity.
I always like to wait more. And after this ridge augmentations procedure, I like to wait at least 6 to 9 months. But this patient actually had a graduation. I believe this patient
Yes,
w- was in the military, and
yes. I
he
was.
had
Their team.
yeah.
Their team were leaving for something, and he needed this fixed.
Yeah, he actually had to leave. Some fond of celebrations, and they had to leave. So actually was pressuring for getting the implant. So a lot of considerations, do we do it or not? Then we ultimately said, okay, let's the healing was favorable from the beginning. The patient is young, is a single tooth defect. We had no complications so far. So I usually take the CBCD at 6 months. In this case, I take it at 5 months. And I place the implant 7 to 9 months. And in this case, I believe I placed the implant at 6 months. So everything was shifted closer. And it's not
Mhm.
something that I recommend on a daily basis, but ultimately we took a risk for this specific patient.
Yep. And that was it. So you need to check. So ideally, but when we look at it, after the implant was placed, um, it seemed you still have to wait for another couple months uh, before we can start. So you did. Um, you had to do an uncovery with this case after a couple months.
So after we place the implant, then the implant needs to wait for osseointegration, right? There are techniques for immediate loading, or immediate temporary restoration, but usually and I tell you that the importance of consulting with different providers is right on the decision on when to applying each technique. So in this case, if we want to give an immediate restoration to the patient, an immediate provisional, I want to speak with you, Dr. Onoriobe, to see pros and cons of this approach. But
Yes.
because it was a canine site that usually gives a very specific and peculiar type of forces, and because we are placing the implant in a regenerated bone, and because we are entering early on, then in this case, I preferred putting the implant in a submerged approach
Yes.
and not to give a restoration the same day. For this reason, I want to put the implant to sleep in a two-stage approach. The implant is submerged, and after 3 to 4 months, then we uncover for the restoration. And yeah.
I know for this case, this implant was placed a little more lingually, would you say, just
Um,
given the cavity patient had in the past?
yeah, for sure, for sure. I tell you that we moved from 2 millimeters to 6 on the coronal side.
Yes.
That is actually very favorable. Nobody says that that is not, it didn't work. But placing an implant that is, this is, I believe, a Nobel parallel 3.75, then 6
Okay.
millimeters is really barely enough.
Mm.
Because then I need to have 1.5, 1.8 millimeter
The five
facial.
on each side.
Yeah.
Yes.
So we need to have two each side. Then it's 6 millimeters, really barely enough. So in this case,
I
I
know.
place the implant to have a good 2 millimeters of buccal bone to ensure
Mhm.
stability of the buccal bone and to prevent the future recessions or
Yes.
dehiscences.
Yes.
So for this
Yes.
reason, in the buccolingual choice of where to place the implant, I went slightly lingual to ensure stability of the buccal bone and to improve the aesthetics and to avoid the recessions on the buccal level. And on the
Mhm.
lingual side, I'm using actually a thick palatal tissue to protect the implant. And then actually that same day, I also scraped some autogenous bone and put some bone on the palatal side, thickening, simultaneously thickening the lingual bone.
Okay. All right. And a patient comes back for the uncovery. I'm going to move on here to that. Yes. So I noticed that you were trying to, for the uncovery, did we have to uh, you wanted to gain some more, keratinized gingiva. So what technique did you use there?
So very often when doing bone, if you see the previous slide, if you see every time we do bone augmentation techniques, we coronally advance the facial flap, and the disadvantage of this coronal advancement of the facial flap is that we move the mucogingival junction more coronal.
Mm,
So what we do, unfortunately, we reduce the vestibular depth and we decrease the amount of keratinized tissue buccal to the site. So if you just do a soft tissue punch coronal to the
I'm gonna look.
implant,
Yeah, yeah,
yeah,
yeah.
then the patient ends up with no critique. So we want to do apically displaced flap, APF, to apically position the flap to reestablish some extent of keratinized tissue buccal to this implant. And then ultimately it improves oral hygiene comfort of the patient. It improves the soft tissue seal in front of the patient buccal to the implant without need of grafting procedures that would have increased the
Mhm.
treatment time, cost for the patient,
Cost,
some
definitely.
discomfort from the wound of the palate.
Okay. So after that, an uncovery was done, and and I was getting ready to see the patient. Patient comes in for, patient comes in for just impression, temporal, provisional restoration, and finally the patient just couldn't wait. He looked at himself in the mirror, and the smile in his face is and the joy. Patient said, "Please, can I give you a hug? You guys have done." I mean, can you imagine what he had been through up to this time? Visiting time in, time out, and the guy was pretty diligent. I don't think he missed any of his appointments. It was a long process, but with collaboration, with planning, with visiting, with sharing information, with patients, with all, and just trying to make sure that this patient was okay, delivered his prosthesis, and I think he also got married. I don't know. I'm
I
thinking
didn't
he
know. I
left.
didn't know. I'm very happy for it. If he got married, I'm very happy for him.
Anyway, so this is what it takes. I decided to show this case. There's several other cases that we could show, but Gianfilippo has a presentation to make today. But this was one collaboration that I'm proud to stick to and talk about anywhere I go. And this is what it takes. It takes details, it takes time, it takes precision, it takes a lot of planning and shared information to make this come to pass. So in conclusion, the contemporary dentist. I think everybody watching right now, you could name yourself as a contemporary dentist. You must recognize that there's too much at stake and too much to know for you to go it alone. You need partnership, and partnership makes this thing so beautiful. Nobody says, "Oh, I did it." We did it. The team effort accomplished this. It's been a wonderful time just sharing about this case. I want to say thank you for sticking out there. Dr. Gianfilippo is going to present something now. But like I said, if you want to get involved in all the things, the implant training is coming in November. We have a class in November. We have a class in January. Send me a message, and you need to get if you are outside the country, you need to get a visa to United States, and obviously the cost to that class, but it is so much worth it. Looking forward to seeing you shortly. I'm going to stop sharing now so that Dr. Gianfilippo can get started with his presentation.
That's amazing presentation, Dr. Onoriobe, and that's really amazing to. First, it's great, always great to see you. You're really a good friend, and then it's great to see you.